Dr. Alfiee Breland-Noble, an Associate Professor of Psychiatry at Georgetown University Medical Center. Dr. Breland-Noble, you talked about racial differences in mental health prevalence. Can you maybe give me an overview? Is there much of a difference, and why is that?
So the difference, it depends on which illness we're talking about, and it depends on whether we're talking about adults or youth. So specifically, statistically speaking, among adults, there are racial differences between African Americans, Latinos, whites, and Asian Americans in certain illnesses, depression being one. Clinically speaking, I don't necessarily know that it's that significant. So statistically, yes. Clinically, I wouldn't say that that's the case. When we talk about youth, what we find in depression specifically, there really are no differences in terms of the prevalence of depression in youth, and very small differences in terms of the prevalence of anxiety in youth.
And then are there also differences in the use of services and getting treatment among the different groups?
Yes, so that's where we find the differences. We find similarities in terms of prevalence, relatively speaking. Where we find the stark differences across race is in terms of who uses care and what kind of care they receive, even once they get into the system. So the differences are in service use, less so in terms of prevalence.
Okay, can you give me a kind of a sense of, the ballpark, what are the differences number-wise?
Oh, okay.
Services of care?
So with the literature that I know is for African American youth. So when we look at African American youth, the estimates are that somewhere close to 65 to 70% of African American youth who need mental health treatment for depression do not get it. Those estimates are lower for white youth. In terms of Latino youth, it depends on which study you're looking at. Some studies say that there are not big disparities in terms of mental health service use, and other studies say that there are differences in terms of mental health service use for this population. But for African American youth, we know that somewhere in the neighborhood of 65-70% don't get care when they need it.
Okay, I know this is a big question, but why is that? And what are the main drivers?
So I would say for African Americans in particular, I think this is also partially true for Latino populations. The main drivers of lack of access or lack of use of care, one, people would argue, is that it's money and whether or not people have insurance. What the research tells us is that is a part of it, but that's not even the largest factor. More so, it is individualized, personalized stigma. I don't want to go to care because I don't want to be seen as having this illness. And I think some of it has to do with sort of the logistics of care. Where is care available? Is there culturally competent care available? Is there going to be someone who looks like me or who understands my experience available for me when I want to seek care? But the biggest ones I would say are these issues around stigma and in terms of the logistics. How do I get care? How do I find somebody who's going to really be able to help me?
Okay, so are you saying, is the feelings of stigma, are those stronger in some communities than others?
Absolutely, that for African American, Latinos, Native Americans, Asian American populations, there is a much greater stigma. I think everybody has stigma, including whites, around mental illness, but for these populations of people of color and marginalized populations, it is much greater.
Okay, and finally, could you tell me a little bit about the AAKOMA Project?
Sure. So the AKOMA Project, African American Knowledge Optimized for Mindfully Healthy Adolescents. Our focus is to try to reduce some of these individualized barriers to care. In other words, how do we reduce stigma and how do we increase the likelihood that an African American family is going to seek depression care for that child or adolescent when it originates. And so part of how we do that is we work with communities in general and faith communities in particular, because that gives us the greatest access to the widest range of African Americans across SES. So that's what we do. Try to develop interventions to increase the likelihood that families are going to seek care for depressed teens.